with us. We have an interpreter who is interpreting in French. So if you are French speaking, you can switch to the French channel. At the bottom, you'll see an icon of the globe and you'll find interpretation there. And we also have an interpreter for sign language, whom I believe is visible to all. Maybe I might just want to be sure that everybody is seeing the interpreter for sign language. Maybe if you can comment if you are seeing her. We have Olivia. Welcome, Olivia. She's interpreting for sign language. Please, can someone comment in the chat if you are seeing the sign language interpreter, so that I can just be sure. Okay, that's great. Okay, that's great. So thank you. So on the French channel, so that is Olivia, who is on the sign language. And we also have Eugene, who is part of the APCA team, who is interpreting in French. Thank you very much. So without much ado, I would like to introduce our presenter for today. Frank, if I can just do a quick check. Okay, Dr. Sem, you're most welcome. I'm just going to read briefly a brief biography of our presenter so that we have an idea who is presenting to us today. And then we can give all the time over to him. Our presenter is Dr. Sem Agate Okwonzi, and he is a Ugandan public health physician, scholar, and researcher. His current research is in global health, health system development, universal health coverage, and health security. For over 2 decades, he researched the impact of free market policies on healthcare systems in Africa. A civil servant for over 20 years, he worked in Uganda government in various positions, including clinical, public health, management, and leadership positions. He then became fully occupied in teaching and research at Makerere University and other universities. He has carried out consultancy widely in Africa on health systems development, with a particular focus on health financing, which makes a lot of his experience very relevant for what we are talking about today. He was nominated as Scientist of the Year 2004 by University of Cambridge for his research on the impact of market-based reforms on health systems. He is a fellow of US-based Social Science Research Council, a member of the International Society for Global Health. Dr. Okwonzi has authored 5 book chapters, over 50 journal articles, 26 conference papers and posters, and over 100 official reports. He is also an editor and peer reviewer of several international scientific journals and conferences. He holds a medical degree from Makerere University, Uganda, a master's in health economics, specializing in health policy, financing, and planning from University of London, UK, and a PhD in public health and policy from the University of Bergen in Norway. Dr. Sem, you are most welcome. It's over to you.
Thank you very much, everybody. I don't know people by name now, but I can see quite a good number of people. I'm privileged and happy to be here presenting this study and analysis on palliative care and also universal health coverage. I just need to share my screen. Can you all see the screen?
Yes, we can.
Okay, so I think we can now move forward. The heading is there, best practices for costing palliative care in sub-Saharan Africa, a case for universal health care coverage. Okay, in this presentation, I'm going to
put the point into sharing into slideshow. If they can put if you could put it in slideshow.
Okay, is that okay? Does that look okay?
Very okay.
Yes.
Very good. So the outline of this presentation is I will give a background, and then I will give methodology on the costing, and then make presentations on findings, various findings of this study. And then I will summarize the key messages from this whole study and analysis. And then I'll try and make a case, frame a case for palliative care, to be included in universal health coverage, and I'll make some policy recommendations. And in the background, I'm going to, because it's important for us to be on the same page, I'm going to try and condense the concept of universal health coverage and some basic understanding of palliative care, and then the work that APCA has been doing. And then I will introduce the costing study, particularly the objectives and the methods and so on. Just to be on the same page, universal health coverage is, it deals with all people having access to health services that they need, when they need them and where they need them. And they should not suffer financial hardship. The key words are without financial hardship. And this is also embodied in the Sustainable Development Goal number 3, which states it in different words, that ensure healthy lives and promote the well-being of all at all ages. Again, these words are very critical, all at all ages. Of course, palliative care is, I'm sure familiar to most of you, is specialized care given to relieve pain and suffering from serious illness, condition, or injury, such as cancer and heart failure, and injuries from maybe road traffic accidents and so on. Now, for purposes of analysis, which I'll do later on, I need to state the aims of palliative care ahead. It is to treat symptoms and also to treat disease, to treat the individual who is sick, the family of that individual, the friends of that individual, and the society in which that individual lives. It also deals with supporting bereavement. In other words, all those arrangements around death. And then it promotes autonomy and assisted living. And it is concerned with counseling and psychological support. And it also deals with ensuring that death is as stressless as possible. So these are critical because they have big social and economic impact on policy. However, that ideal definition of universal health coverage does not actually exist in real life. Universal health coverage has only been fully achieved in some of the highly industrialized countries. And even in some, like the US, universal health coverage has been blocked by some negative policies. In the case of US, it is related to race. But in low and middle income countries, few countries have achieved or attained universal health coverage. There are those that have achieved it with narrow packages, but the majority, even those narrow packages, do not cover the entire population. And now COVID has brought in a new dimension and a new quickening of activities to relaunch and to launch universal health coverage. And the examples that are happening right now as we speak, they include Brazil, Chile, Colombia, Malaysia, and I'm sure most of the African countries have embarked on expanding or attaining universal health coverage under different programs. And then of course, the reality of palliative care is also quite different from what we define in ideal terms. Most universal health coverage packages exclude palliative care. They don't mention it. Sometimes it is there, sometimes it is not there. But palliative care mostly is viewed as expensive, non-economical, and non-beneficial. And it is viewed as something that has high initial investment, particularly in terms of technology and assisted devices. In most packages that you look at in Africa, the packages for universal health coverage consist of maternal child health, reproductive health, selected infectious diseases, mainly malaria, HIV, AIDS, and things like that, and non-communicable diseases, which are now increasing. But normally they don't mention palliative care. And so I guess that when the African Palliative Care Association was formed some 20 years back, they were worried about the highest level of need for palliative care being in Africa and not being met. And particularly, more than half of the children who are in need of palliative care globally are found in Africa. And so the African Palliative Care Association was formed to address and to begin to think really about how we can cover the area of palliative care on the continent. And so it has a vision which is something that is good also for analysis: palliative care for all in Africa. And the mission is to make it palliative care widely understood and integrated into health systems. So this is critical for us to know, because in the end, it will guide also in the analysis. And so in 2019, APCA started the strategic advocacy on inclusion of palliative care in universal health care, in universal health coverage in Kenya, Uganda, and South Africa. And I think the first initiative was to start with Kenya. And the study was to lead to a manual that would enable many countries to adopt a method of integrating the costs and the planning into the essential health packages that most African countries are using. So this study had 4 objectives. One was to provide a background information to palliative care costing, to carry out cost and benefit analysis, and to carry out affordability analysis, and then to provide a realistic revision of palliative care costs for integration. And so we, as a team of researchers, we had to review documents, and we particularly reviewed documents from Kenya on the health, generally on development, but also on the health sector specifically. And then we did the costing of palliative care, and we used a cost and benefit analysis technique. This is a computer program. But in this computer program, there are several things that we need to take note of because this is the information which is fed into that computer program. And the first one, the assumptions that were used for analyzing and costing the palliative care include, one, that the need for palliative care will be calculated from the NCD growth, non-communicable disease growth rate. This is just a way of estimating, because a longer study would probably need other types of criteria. But the closest that we came to was the growth rate of NCDs, because they are the ones that are heavily connected to palliative care currently. And we also assume that palliative care coverage will be scaled from our estimation from the current, which is about 10% to 25% in the first year. And we are really aiming to move to 100% in 5 years as planners. And step 2 is to identify the main cost items, which were grouped as follows. 1 is the essential palliative care medicine. There's a wide range of medicines that need to be costed. Also, the essential equipment, patient supportive devices, technologies, and supplies. This was a second category. Then human resources, both numbers and training. And then we have the psychosocial interventions. And there were other costs that could not fit into those upper categories. All of them were lumped together under other costs. And here we try to identify the percentages of days with symptoms in order to estimate the quantity of symptoms suffered by the people who need palliative care. And as you can see, most of the symptoms are here, the biggest being dementia, which is 23%. And then there are others which are also quite prominent: weakness and fatigue. We have wounds, we have anxiety and worry, and so on. So this gives you a breakdown of the type of suffering or symptoms that people who need palliative care go through. And step 4 is estimating the costing of essential medicines Here we used all this, of course, information is programmed in the computer, that we have essential medicine cost, which will be equal to cost per unit times the standard daily dosage times the percentage of times the drug is issued times duration of that whole treatment episode, and then times the palliative demand, that is for population size. How many people are in need of that palliative care service? Step 5 is costing essential equipment, and the equipment will be derived, equipment cost will be derived from cost per unit times duration times the demand size. Again, this is the population in terms of numbers of people. And step 6 is costing human resource. Here, human resource cost will be percentage of staff time spent on palliative care times the staff salary times the demand size for palliative care. And step 7, costing psychosocial support. This is the subsidy amount times palliative demand in need of subsidies. So these are the 7 steps which are used for costing. And then here we have now the computing of the benefits. What are the benefits of palliative care? And here we identified the following benefits. One is reduction in inpatient stay, reduction in mean stay in hospital, reduction in multiple re-hospitalization, and reduction in hospital visits by relatives and friends and so on. Increased number of productive years. For example, after they have got better, they can get back to work, or they can release members of their family to go and do some work. And then reduced need for care by relatives. Step 2, compute the reduced inpatient stay. And here we have reduced inpatient stay, which will be equal to inpatient minus home-based care times reduction in number of admitted patients. Step 3, compute the reduced hospital stay. And here we put reduced hospital stay, which will be equal to admission cost per patient times the number of admitted patients times the present value interest factor. This factor has been determined already statistically. And then step 4, compute the reduced number of rehospitalizations. Here we have the benefits of reduced number of rehospitalizations that will be equal to savings from reduced number of rehospitalizations times the number of patients admitted times the present value interest factor. And step 5 is to compute the reduced hospital visits by family members. Reduced hospital visits by family members will be equal to average reduction of hospital visits per patient times discounted GDP contribution per person per day. This is all calculated. Now, all these steps which I'm explaining are already programmed, and they just automatically bring the results. But I just need to go through so that you know what kind of information has been fed in. And then compute the increase in the number of years of productive life. So increased number of productive years is equal to non-dissident adults, of course, those who have not died, minus the number of those who have died at that time, times discounted GDP contribution per person per day. And step 7 is to compute the reduced number of care by relatives. And this is equal to reduction of patients in number of caregiver times GDP per capita contribution. And step 8 will be to compute the rate on investment on palliative care. And here we are looking at ROI, which will be total number of benefits divided by total costs incurred. And then we had to do the analysis because some of those assumptions were ideal, but the reality on the ground in Kenya, and of course elsewhere in Africa, and really around the world, the realities are very different. And so the basis of affordability decisions included the following. One was that we felt that it was going to be feasible to repurpose, or in other words, mobilize existing resources, that there are resources that can be mobilized and can add up to 50% of what we need to do palliative care. So in other words, you don't need really additional resources to that tune. And then B, target additional budget allocation to palliative care at, we're looking at two scenarios. Initially, we wanted to look at 30% because they are pressing priorities as well. Palliative care is not the only pressing priority. And so we cannot allocate too much from additional budget allocation from government. But we are looking at a case where the matter is understood, the pressure of advocacy has been felt, and that people know that we need more resources to address the issues of palliative care. And so we're looking at 30% and as well as 50% initially, especially in the first 5 years. And then C, strong and persistent advocacy will be needed to drive this whole thing, because many people are quite negative or not very positive about including palliative care at this rate. And then a 10% increase of total health budget per annum for the whole of palliative, for the whole of health expenditure should be achieved. Otherwise, we cannot go far, because the current level of funding can just do as much as I've already said, that we mobilize only 50% of what we need from existing resources. But over the years, we need a continuous, at least 10% increase in total health budget for us to be able to move further to expand palliative care services. And then government funding. Okay, we know that currently palliative care in Kenya is being addressed mostly by the private sector, and the poor are losing out totally on these services. So we are proposing that within the next 5 years or so, government funding should target the poor, which is 46% of Kenya's population, 46%. And then finally, the palliative care expansion in the essential, in the universal health coverage should also target government funding. And we also know that government funding is only 53% of total health expenditure in Kenya, only 53%. The rest is being funded by the private sector or by the households. Okay, so these are some of the facts and figures that one needs to know before you go into serious analysis. For example, we know that health expenditure in Kenya is Kenya shilling 7,822, and yet the desired budget, according to the Abuja Declaration, which Kenya aspires to get, is 13,037 Kenya shillings per person per year. Now, we also know that from our calculations that the ideal palliative care cost in Kenya would actually be 19,000 Kenya shillings 560, which is far far ahead of what is available. And then, of course, we have the other budget limits. The budget allocation to health is just 6.7% of the total budget and so on. And then we have a desired budget allocation of 15%, which is the Abuja Declaration. But that is not yet possible because of the pressures of other demands. So we now say that the best way to integrate palliative care in universal health coverage is to do it slowly over time. And we are assuming, and the ministry documents give us hope that they are aiming to get at least 10% annual budget growth over the next 5 years. Okay, the years which are about to end, because we are reading a budget or a strategic plan which is almost ending. At 10% annual growth, and if it is more, that would be better, but 10% is good enough. And then we're saying that 30% allocation could be made to palliative care. But even this 30% actually is not going to cover some of the basic things. So we are saying we have maybe in the initial 5 years, we need to give some focus on palliative care and increase it to 50% so that the rest of the other 50% can go to the other services of the health system. And so we, of course, also read the background to Kenya's national development policies, and we note some of the key things which may be familiar, but it's important for analysis. That is the right to health, the highest possible level of health, equity in health, and public participation. That is the Constitution of 2010. And also Kenya's Vision 2030 says that Kenya is going to be, by the year 2030, Kenya is going to be a globally competitive country, a prosperous country, industrialized country, and that all this will depend or be driven by health as an economic development driver. And then we have, of course, the national health policy, which started in 2014, which is going to end in 2030, which gives us two key points. One is that the quality and distribution of health services in Kenya should be at par with its middle income status. At par with middle income status. In other words, Kenya is ahead of many countries which have not reached middle income status. So they cannot, Kenyans cannot really have the same level of or the standard or quality or even distribution of services like the poorer countries. And then, of course, there should be universal coverage by the year 2030. Whatever they define it to be, there should be some level or some kind of universal coverage in year 2030. And we are saying, of course, that that coverage should include palliative care. And then, of course, we have Kenya's health priorities. It's important to know where we are with Kenya's priorities before we even come to think of the other things. The first one is maternal child health. Then they have specific infectious diseases in mind: malaria, TB, and HIV. Then we have nutrition, the NCDs, water and sanitation, mental health, adolescent health, and the neglected tropical diseases, and the health system. So these are the priorities. In other words, these are priorities that the whole of the Kenya's budget and resources are being devoted to. And the aspirations that you see that Kenya is following include 100% facilities to provide the essential health package. That package has been well defined. We have just seen some of the elements. And then 100% of the population who should be living within 5 kilometers of a health facility. 80% of hard to reach areas are covered by the essential health package. And 100% of the people are insured. And household expenditure on health is less than 40% of total household budget. And I think you remember, we just talked about people should not be stressed financially while trying to get healthcare. And of course, there are also certain major risks in Kenya, which is a big concern for the people who are planning health services. The first one is unsafe sex. And then we have short gestation, women deliver too early, and then low birth weight. The children, the babies are very small and not able to, some of them are not able to survive. Child wasting, this is due to malnutrition, unsafe water, alcohol and substance abuse, household pollution, lack of hand washing facilities, and high sugar consumption, and then road traffic accidents. Now, these last two, where I put some X's, are closely related to palliative care eventually. We know that high sugar consumption leads to diabetes, and diabetes has its own issues which lead to palliative care needs. And then road traffic accidents are also common, and these obviously we know are immediately related to the need for palliative care. Then we have the National Strategic Plan objectives. These are just to remind us, and also we use this as a basis for some of the analysis that we work later on, especially for policy, that we need to increase the package coverage, the size of the package, but also the coverage, increase prepayment. In other words, save people from financial stress, increase the scope of the benefit package, improve the quality, protect people from catastrophic expenditure. I've already said this, provide supplies for healthcare, and improve leadership and governance. All that is linked to planning properly and ensuring that all the objectives are achieved. Then we have the universal health coverage roadmap that Kenya is following. I have not seen, I didn't see a midterm evaluation of this roadmap, but it was said that in the first phase, 3 million people in Kenya would be covered by universal health coverage. 3 million. Of course, that is still a small number. And then after the 3 million, they were going to cover all secondary school students. I'm not familiar with the number of secondary school students, but they must be quite a big number. And then we have phase 3, to provide free maternity for 1 million mothers. How these 1 million mothers are going to be selected, it was not quite clear to me, but that's the total number they have estimated. And phase 4 is abolition of user fees, targeting 7 million children. In other words, all children who have a health problem, out of those children, 7 million of them would be helped by the abolition of user fees. And then phase 6, health insurance for 181,000 households. And say phase 6 is cover the elderly, those who are possibly above 60, cover them with the essential health package, targeting 42,000 households. So this is the roadmap. But also there were strategic actions that Kenya has been following And it's important to know this because this is where most of the resources and efforts are being made, is to eradicate polio and guinea worms, to eliminate HIV, malaria, newborn tetanus, measles, and NTDs and leprosy, to focus on special groups. And there are some special groups that Kenya has been targeting to help: women, people with disabilities, the elderly, the youth, and so on. And so you can see the number is quite a good number. You can even see the people who are in the barracks, refugees, prisoners, commercial sex workers, and children and the youth, and so on. So it's a very big group, and these are generally what I would call disadvantaged groups. Then the fourth one is to ensure health security through early warnings and rapid response. This, of course, is in relation to epidemics and disasters. And this is also in relation to health security. But Kenya's health policies, which we have just gone through, do not mention palliative care. In other words, palliative care may be there, but it is actually behind these policies. It is hidden. There is no specific mention or measure, and palliative care is subsumed to be part of the essential health package. But it is visibly absent in public services, reports, and plans. Only some private facilities are mentioned as being dedicated to providing palliative care. So these are some of the results that we got for the costs. And as you can see, these costs are in Kenya shillings per annum, and the percentages are there. And what you note immediately is that the human resource takes 35%, 35%. And that's why we said we can repurpose some of the human resource, because that's where a lot of the resources are. And then we, of course, have other costs, which are also 28%, and this can also be shared. And then, of course, we have equipment, which is also fairly heavy, which is 16%. Surprisingly, the essential medicines covers only 6% of the total expenditure, total cost. And then here we have the costs that we estimate over the next 5 years, first year, second year, and so on. As you can see, the numbers, the proportion, the amount of money that is going to be spent, that is estimated to be spent on cost palliative care, will be increasing quite rapidly, and then it will stabilize around year 4, and begin to stabilize. And of course, if we project it further, it may now stabilize around 35, 36,000. I don't know, this is million Kenya shillings. And if you look down here, per capita, it comes to 19,000 Kenya shillings in the first year per person. And in the 5th year, it is 53,000 Kenya shillings per person per year in the 5th year. And the benefits are also projected here. And you can see the benefits are, of course, monetized, and in order for us to compare it with the costs. And so in the first year, it will be 26,000. No, 26. This must be really in billions. And in the 5th year, it will be 105 billion Kenya shillings. And so we have the scenario in year 1, where we have costs and then we have benefits. In year 1, the benefits are 26.8 billion divided by 12.5, and so it is going to be 2.148 times as the rate of the rate of return on investment, which is going to be 2 times 1.48, 2 times 1.148 times. And in the 5th year, it will be 2.6, almost 2.7 times. In other words, the costs will be offset totally by the benefits of palliative care. So this is just a summary of what we presented here. The ideal palliative care investment is 19,000 Kenya shillings per capita in 1 year, and this could increase to 53,000 Kenya shillings per capita in the 5th year. But entire health package in Kenya is only 7,822 shillings per capita. So there's also a funding gap of 15% currently. I hope this gap somehow has been filled, but at the beginning of this planning phase, there was already a gap of 15% in national health budget. And also we know that government funds only 53 or 52% of the national budget, and households are supposed to fund 33%, and 15%, of course, is a gap. So the decisions we came up with are that we need to repurpose half, at least half, and we felt this half was possible from existing resources, particularly the human resources can be trained, can be repurposed, can be made to do, double work, not really double work, but something that they can do as a continuum of service to a patient. And so we would offset Kenya shillings 9,780 per person. And if you target only government funding for the poor, you would end up getting 5,086 Kenya shillings per capita. And if you target the poor initially, that is target the poor for palliative care, you will end up getting 2,340 Kenya shillings. And so target additional allocation from health budget increases. That would mean that you increase the budget at least at 10% per annum over the next several years, 5 years and above, and allocate, and we suggest that we should allocate either 30 or 50% scenarios to palliative care. And all this has to be supported by strong advocacy and lobbying, because many people may not take it lying down to get so much money for palliative care, as opposed to other priority areas. Okay, so this is what we eventually came up with as the total, the total. I don't know if I can't get the screen to move down a little bit, but as we can see, the total health expenditure in base year, let's say base year is now, is about 7,822 Kenya shillings per person per year. That is in the base year. And now in year 1, it will be 8,200. In year 2, it will be 8,600, and so on. It will go up to 9,000. That is if there is a growth of 10% in the total expenditure of on health. But if we allocate 30% of what has already been added, or of the 10%, these are the rates that you see in the second column. And there is still a deficit. There is a deficit. And the deficits are quite big. But the deficits reduce over time, and the amount that is dedicated to palliative care increases over time. And if it's at 50%, as you can see, the numbers are quite bigger, and we reach almost half of what is required for palliative care that originally was planned in the 5th year. But we still need more money. So a number of factors may have to come in, either the annual growth rate of expenditure increases, or the allocation to palliative care increases. But I think it is better to leave it to grow at the rate of all the other things over the next 5 to 10 years. And then we shall be able to reach the required level of funding. So this is just like a summary, just to remind you that the ideal computed palliative care costs would be in year 1, 19,560 per capita. In year 5, 53,285, and the total cost would be 12 billion, 0.5. And in year 5, it would be 141 billion, 0.1 billion. And the ideal computed palliative care benefits would then be total benefits 26 billion, and total total costs would be 26 billion, and total benefits would be these are benefits here. In year 1 will be 26.8, and year 5 will be 377.6. And then, of course, the rate of return, we've already gone through that, would be coming to this. Now, the conclusion here is that for every $10 spent on palliative care, the benefits are $27, and which is quite economic. In economic terms, this is very useful. If you have a business which is doing so well, you have no problem really. If you have a business of that nature, that you spend only $10, but in return you get $27. That would be very good business. But of course, most people don't see this, because this is dealing with life, and this is dealing with the people's livelihood. And then, of course, we have the Kenya shillings 1,259 out of the required 2,340, which can be mobilized if government spending grows by 10%, and if we allocate that increase by 50% to palliative care. And note that there will still be a funding gap of Kenya shillings 1,081 per capita, times the present value factor over the years, which will need to be covered. And that gap can only be bridged by the rate of increase of allocation and the growth of the budget as a whole. So these are some of the messages that we are getting from this whole study, and also this whole analysis, that palliative care is socially and economically beneficial. And palliative care costs are quite high, but they require deliberate planning and deliberate investment. And as I've already suggested, some of the existing resources, equipment, human resources, and so on, can be repurposed. The current health expenditure in Kenya requires phasing. at an affordable rate. Of course, you cannot break the back of the government just for one item, which is palliative care. So we have to move at a pace which is affordable. And that affordable rate is dependent on health budgets, but also the economy as a whole. You target government funding for the poor initially. The poor have got to be covered because the rich may be able to afford palliative care, and integrate palliative care into the essential health care package, and then eventually, of course, into the universal health coverage. We need to take palliative care as a continuum of health care. This should not be separated from the others. I think that's one of the issues that is coming clearly. Perhaps even that's why the documents don't tend to mention it. But since since it's not clearly seen, it's better that we mention it. But it is part of the continuum of care that we should all aim at. Okay, so these are some of the recommendations that let me see. Okay, these are some of the continuing messages that we're getting. The socioeconomic benefits of investment are high. Palliative care should be seen and treated as a continuum of care. The NCDs and injury are likely to generate growing demand for palliative care. These issues are actually increasing rapidly in Kenya. The level of NCDs and the level of injury, particularly from road traffic accidents. And so that will generate more demand for palliative care. Africa has the highest level of palliative care needs in the world. And there is need for concerted effort to address it. And we cannot just leave it to be hidden behind policies. It must come out on the table and it must be addressed and then deliberately integrated into health services. And particularly for Kenya, Kenya is a middle income country and is expected to provide services at the level of a middle income country. And that includes palliative care. And palliative care budget has to be implemented in a phased but affordable manner. It has to be phased, it has to be affordable. And of course, there has to be some strong advocacy for people to understand the need to include palliative care. And so there's need to build the advocacy program to persuade policymakers, decision makers, and other stakeholders. And then consider human resources, human rights, in addition to socio-economic benefits. Now here, of course, there are people who may not be fully convinced about the economic benefits of palliative care. But just being a human being is enough to render, to give a right to a person to get palliative care. So human rights are strong reason enough to demand for palliative care. We need to repurpose existing resources, and we need a special focus on the poor. Okay, so these are some of the specific policy recommendations. Because I did not see, later on I was told that there may be some strategies and plans. I've not seen them myself, and I think my colleagues who did part of this work also didn't see. So what we're making a recommendation of here is that there has to be a financing strategy for palliative care to integrate it into essential health package and universal health coverage. that strategy must be very well thought out and must be affordable, must be in line with financial and economic policies. And of course, there must be public awareness as well as lobbying to make people understand the relevance and the importance of palliative care. Then policy guidance should be given to the private sector because they're already handling palliative care. They could be encouraged to enlarge it. They could be encouraged to work in line with the, or alongside in partnership with the public sector institutions. So a policy guide should be made for the private sector of palliative care. The second issue is to make a 5-year strategic plan in order to promote and incorporate palliative care as part of essential health package. In other words, absorbing palliative care is not going to be automatic just because there is a lobby for it. No, there has to be a deliberate strategic plan with specific targets, indicators, and particular areas of focus. And then over a period of time, we can measure the level of that integration and the level of care that is for palliative services. Number 3 is to develop a monitoring and evaluation plan, particularly to assess the following areas. One is to assess the use of palliative care services. How much are palliative care services available, and at what rate are they being used? Because it's one thing to have the palliative services available, but it's another thing whether those services are actually being used by the population. Then the availability of critical drugs and equipment, those the necessary things that are required for palliative care service delivery. And then C, to measure palliative care human resource numbers and capacities. That kind of assessment has to be made. How many human resource, how many staff are we talking about who are involved in palliative care? What capacities do they have? And what do they need in order to reach out for more services? And then we also need to look back and see just what are the benefits of the services that we're giving in form of palliative care, in terms of the individual, in terms of the family, in terms of the society or the community where that individual lives. Somebody has to do this study. Now, these are not small studies, and these are not things that you just do in 1 or 2 days. So it has to be planned properly. And this will be necessary for planning in front, integration ahead. Then number 4 is develop a 5-year palliative care advocacy plan. Now, advocacy is critical because it is to make people understand the importance and also to plan for its integration. And this palliative care advocacy plan must have its own indicators and targets. Otherwise, it is just going to sit and nobody will be caring about it. So it needs its own plan plus resources and plus periodic follow-up with the reports that this is where the advocacy plan has reached. So it has to be planned properly. And then when all these efforts are put together, it can be assessed mid-term and then end term to see just how far we have come. Okay, so I think this is it. Thank you very much for listening to me. I hope I've not taken too long. Thank you. Hello? Can you hear me?
Thank you very much, Dr. Sam.
With Rai, your line is breaking up. Maybe you can turn off the video.
Thank you for that very detailed and very interesting presentation. Yes, we can hear you. Hello, are you getting me now, Dr. Man?
Yes, we are getting you now.
I'm just doing some check. Are you getting
Your line is breaking up. Maybe you could turn off the video because the line is breaking up. Was Rai, are you there?
Yes, I just got back in. Sorry about that. It's my network that's a bit erratic today. Yes, but I was just saying thank you very much, Dr. Sam, for that presentation. We are looking out for any questions in the Q&A section. So far, there aren't any, but we've seen a couple of comments that have been posted in the chat. So maybe we can just address those. But in the meantime, I just wanted to, if you have any questions, please put any questions for Dr. Sam in the Q&A section. You will see you have access to it at the bottom. Please post your questions there or comments that comments on the presentation that you would like to be acknowledged in the next couple of minutes when we are having this brief discussion. Now, I just want to acknowledge also our colleagues, the Kenya Hospice and Palliative Care Association, who are here with us, who hosted the study. As you heard, this was based on work that was done in Kenya. It's a public holiday today in Kenya, but they are here with us, so we acknowledge that. We acknowledge your presence, and also just to note that they are also going to host a dissemination of the same in country sometime in the new year. So I think we can keep our eye on their social media and their online platforms to maybe participate in that if we wish to get to know more on the first-hand information on that. I've also posted a link to a related presentation that's coming up in the next maybe 45 or so minutes. It's talking about, it's being hosted by the European Association of Palliative Care. They've extended that invitation to us and to all our partners as well. If you're interested, it's talking about, the topic is the economics of palliative care. So it will be related, it won't be as detailed, and it won't be sub-Saharan Africa oriented. It will be a bit more, probably more Euro focused, but I think it could be valuable to members who are in this webinar as well. Also just quickly to acknowledge all our other partners who inputted into the development of our essential package for palliative care in UHC. I've seen quite a number of them represented from different sections of the continent. I've seen Eastern Africa, Southern Africa, and West Africa, and all the other regions. Thank you for being here. If there are, I still don't see questions in the Q&A. Okay, there are now a good number of them. Okay. Okay, there is a question, Dr. Sam, if you can possibly respond to that. The first question, would you like to read them yourself or would you like me to read them out for you?
Yeah, you read for me, please.
Okay, so the first one is saying, do you have a graph from Ann Sanders? It says, do you have a graph to show where Kenya is on its national health policy? Where Kenya is on its national health policy? Is it ahead? Is it on target, or is it behind in the different areas? Is there a way you could maybe show that on a graph, or if not, maybe comment on that?
No, I actually tried to look for where Kenya is, even in the strategic plan and in the policy, I didn't see any report as to how far Kenya has come. I'm looking forward to a report of that nature, or a study, maybe somebody has to do a study to see where Kenya has come with regard to the national health policy and the national strategic plan.
Okay, so I think maybe if you could also attend, if you could keep an eye on the KEPCA platforms, so that in case they have those details when they do their dissemination of the same, maybe that could be answered. Then there's a question that's talking about from Dr. Agasha. It's saying also, please clarify which countries have been targeted for the costing study that you are doing. I think you can answer that. If not, maybe Dr. Emmanuel can help us with that. I'm going to read a couple of questions, then you can maybe respond to all of them. So this one is saying, which countries have been targeted for the costing studies? And then the next one says, thank you very much for the presentation, Ben. Shiman is saying, what is the policy in place to take palliative care services to other African countries that never heard about it? This is Dr. Benjamin Chiman. I think you can respond to that, Dr. Sem, and I think Dr. Emmanuel might also want to say something about that. What is the policy in place to take palliative care services to other African countries that have never heard about it? And then there is also a comment from Maculine from KEPCA. Great presentation, Dr. Sem. KEPCA is interested in further discussion how the recommendations can be tailored for advocacy. Definitely, because now when we have all the social and economic benefits of this, I think we can tailor some very sharp and direct messages in advocacy. Thank you for that. So let me leave you a moment to maybe respond to those 2-3 questions that you've raised.
Okay, thank you very much. I appreciate the comments. The countries that I immediately saw that are being planned for are South Africa and Uganda, in addition to Kenya. But I am sure Dr. Emmanuel will give us a better picture of the longer or the bigger plan for palliative care in Africa. Then on the policy of expanding or extending palliative care message to the rest of Africa, I think this is where advocacy comes in, raising awareness initially and doing studies just to quantify the need for palliative care in the various countries, and then starting to plan. Because without this basic information, many planners, political actors, and the Ministry of Health staff will wonder how they can actually plan for palliative care. So it's important to raise awareness, do strong advocacy, but also do gather information that is critical for planning. I think those are the main ones that I could address.
Thank you. Dr. Emmanuel, do you want to say something?
Yes, thank you very much, Dr. Sam, for that very, very rich and enabling presentation, which gives us a lot of energy now to move forward. I think you've put things across so clearly, and the fact that we can demonstrate benefit as compared to the investment by government, that pushes us miles away, and I'm really very excited about that. Just to answer some of the questions on the issue of which countries, of course, Uganda, Kenya, and South Africa were the main countries that we focused on this. And the reason why Kenya was the first pilot country is because Uganda is a low income country, Kenya is lower middle income, and South Africa is high middle income. So Kenya is in between. So the model that has been developed in Kenya could be adapted to what is in Uganda and also adapted to what is in South Africa, given the fact that it's middle between the two economies. So in terms of expanding to other countries, somebody asked a question. That's why we have the Ministers of Health session on palliative care, which is also an advocacy forum. And we had one meeting, one session this year in Kampala here, where we had various countries. But I think the next move is for countries to work with us and pick the same tools, and we do what needs to be done in those particular countries, and then we set the ball rolling. So definitely, Edwina, this is something that we can replicate in other countries using the same tools. In terms of wider advocacy in your countries, please get in touch with us, and then we can together work out a mechanism of reaching your heads of state, reaching your ministers of health, reaching your parliament, and reaching your ministries of finance. The advantage we have is that the Director General of WHO already wrote to each head of state about palliative care, and we can just follow up using that letter which the Director General wrote, and then we use that as a step to access those countries. Thank you very much.
Thank you, Dr. Emmanuel. Thank you for those responses. I'm just going to read one last comment. We just have a couple of minutes to the to finishing time. There's another comment by Dr. Agasha. Thank you for the presentation. I have gained much insight in costing. I look forward to the day we can tell our governments in Africa the actual gains made financially when patients receive palliative care compared to when they do not. My question to the presenter is, do you feel that Africa is in a position to quantify the amount of money spent with and without palliative care services? Then there was also another comment that was posted in French, and Eugene, you can be ready to share any others. There was a comment in the chat that was asking about when is palliative care, how can we get palliative care training in Kinshasa or in the DRC? Maybe Dr. Emmanuel, you respond to that also. Over to you, Dr. Sam.
Okay, thank you very much. Quantifying, this requires studies. But of course, first one has to be interested to assess the need for palliative care in a country, and then as part of the work to plan for palliative care services, some basic studies have got to be done, and some of these studies will include quantifying the necessary requirements, but also the amount of funding that is within the health sector or within the services, healthcare services, that can be either rechanneled or repurposed or shared for palliative care services. So it requires a little bit of background, what I would call fact-finding study in a country that has not planned it at all. Fact-finding study, just to see what is available and what needs to be done. Then subsequent studies can be planned so that specific quantities of funding and of the work that is needed to be addressed can be done. Now for the training, I think there are different places where this training is done. My own take is that instead of doing the training abroad, these trainings could actually be instituted in our local universities and institutions. And so there has to be also a way in which studies begin to be done to integrate or to create palliative care studies or courses within our own institutions. But of course, I will leave that to Dr. Emmanuel because he's the person behind some of these trainings.
Thank you very much, Dr. Sam. I indeed agree on the training bit. We need to sort of domesticate training. And I'd somehow responded to the person from Kinshasa so that they can get in touch with us and we work together to see how that can happen. We've already had some experience on how we can do that, given the project that we've been running with UNODC in Democratic Republic of Congo over the last 2 years. And we can build on that, and also by utilizing the eco platforms to develop capacity within DRC and working with our colleagues from the civil society, but also from the university and Ministry of Health, so that we can have training happen within DRC itself. So definitely, that's something that we can work on together and ensure that the training happens, as is happening in Uganda, in Malawi, in South Africa. There is also another project which we are currently in the very early stages of working on with the University of Cape Town, which is actually aimed at building clinical leadership within countries. And we can also design that better. So definitely, better things are yet to come, and we can develop the training within country, in those countries. Yeah, thank you very much.
Thank you, Dr. Emmanuel. We've gone just a couple of minutes past 4:30 now. There was just one last question that I did manage to cover. If you can indulge us, we can just ask that question. The budget is far bigger than the country health allocated budget. Won't this make advocacy for palliative care integration very difficult? I think it's based on the figures that you presented for Kenya. The budget is far bigger than the country health allocated budget. Won't this make advocacy for palliative care integration very difficult?
Okay. This is exactly what this presentation is, the point that this presentation is trying to make, that the ideal situation for palliative care is far more costly than what most government budgets or most countries, even private sector budgets, household budgets can afford. So the case we're putting here is that we have to start with existing resources, and we have to first assess what is available, what can be repurposed, particularly equipment and human resource. And then we have to phase any increase to the health budget to include palliative care over time. So it is phasing in integration over time. That is the strategy. And that is the strategy that the strategy message that I would like to leave for the other countries that have not yet participated in this program, that it is through integration and also through phasing that we can reach our target. That it will not happen just in 1 year. It will take several years, but it will require a lot of lobbying, a lot of education, a lot of awareness raising, and then over time, palliative care will become just one of the services as a continuum of healthcare in that country. Thank you.
Thank you. Thank you very much, Dr. Sam. And let me just conclude by thanking everyone who made it to the webinar today. We hope you've had a great UHC day. I also just want to make a quick announcement. Maybe it's also slightly responding to one question that I've seen in there that's talking about young people and student bodies. APCA supports the work of students, associations, and also academic institutions for health professionals that are advocating for the integration of palliative care into training curriculums and also recognition of palliative care qualifications. We've worked with quite a number of countries, and others have developed degree programs, diploma programs, certificate programs, and so on. So if there is that kind of interest, you can also approach APCA, and we can work with you to do, whether it's capacity, whether it's advocacy, whether it's a small grant that can support that kind of work in your country. There was a question from South Sudan that was asking about how we can involve students and young people also in palliative care. So in palliative care, we actually have a project coming up next year where we will be working with students of health professionals who are students and who wish to train in palliative care. So thank you very much. If you keep an eye on this, on our platforms, you will be getting that information in the upcoming weeks. We will be sharing that information. Thank you very much for your time, and thank you for your input and for all the questions and the engagement. And Dr. Sam, thank you for the splendid work that you've done. You can see there's a lot of questions and a lot of interest to know more, especially in our different countries, to see how we can replicate the study and have the same model in the different countries. Thank you very much. We've come to the end of the session.
Thank you very much indeed. And well done, everybody, for being around. Thank you and good day.